Next topic, preeclampsia. Coming to the definition, preeclampsia is a multisystem disorder of unknown etiology characterized by development of hypertension along with proteinuria after 20 weeks of gestation in a previously normotensive and non-proteinuric woman. So, what's the level of hypertension we are looking at? 140 over 90, greater than that, proteinuria greater than 0.3 grams per 24-hour urine specimen after 20 weeks. It significantly contributes to maternal and perinatal morbidity and mortality. So, till here it was the definition. The disorder can progress rapidly, necessitating close monitoring and prompt intervention to prevent severe complications, including eclampsia and maternal death. Coming to the pathophysiology, preeclampsia is primarily caused by endothelial dysfunction and vasospasm, leading to reduced placental perfusion and systemic inflammation. So, let us look at a flow chart. It would be really nice if we had a flow chart, but we don't. Path of preeclampsia. Yeah, so here a very nice flow chart. Yeah, so here this might be a good one. So yeah, here everything is all over the place, no need of this. Yeah, this one, abnormal spiral artery remodeling, reduced cytotrophoblast invasion and proliferation, placental hypoxia, placental ischemia and increased oxidative stress, decreased blood flow, and overall there is abnormal angiogenesis like increased BP and all that. So yeah, coming back, it's caused by endothelial dysfunction and vasospasm, leading to reduced perfusion of placenta and systemic inflammation. So specifically it is the trophoblastic invasion of spiral arteries which is incomplete, resulting in high resistance and low blood flow to the placenta. So the placental arteries, so the spiral arteries shouldn't have so much of resistance. So but if when they have a lot of resistance, there is low blood flow to the placenta, and this hypoxic environment leads to the release of anti-angiogenic factors such as SFLT1 and endoglin, which further impairs the endothelial function, causing further vascular damage and organ dysfunction. So key mediators are these, and overall it is the hypoxia like situation which is developed because the trophoblastic invasion of spiral arteries being incomplete, and there is vasospasm and endothelial dysfunction. What are the risk factors? So several risk factors are responsible for the development of preeclampsia, main ones being primary gravida, first pregnancy, advanced maternal age, pre-existing hypertension or renal disease, multiple gestations, obesity, history of preeclampsia in previous pregnancy, autoimmune diseases, diabetes mellitus, thrombophilias. Coming to the clinical features, features in general, then clinical features specifically. These are the clinical features. Yeah, so we are looking at a specific criteria. So when any of these criteria are met, it is termed as severe preeclampsia. So for that we need severe hypertension which is greater than 160 over 110 mmHg at measured at least 4 hours apart. That is one. Proteinuria greater than 5 grams per 24 hours urine specimen, or greater than 3 plus on dipstick. So that is another one. So proteinuria, severe hypertension. Oliguria, urine output less than 400 ml every 24 hours, and elevated liver enzymes suggesting hepatic dysfunction, cerebral and visual disturbances including persistent headache, blurred vision, scotomas, thrombocytopenia, platelet less than 100 K, and pulmonary edema due to fluid overload. Epigastric or right upper quadrant pain suggesting of hepatic involvement. So there is hepatic involvement in suggesting hepatic involvement. For that particular thing we have liver enzyme tests and pain specifically, and there are thrombocytopenia like features too. Yeah, coming to the next one, symptoms suggesting of imminent eclampsia. So severe persistent headache unresponsive to analgesics. So headaches, visual disturbances we have already seen, epigastric pain, right upper quadrant pain, due to hepatic involvement, severe nausea, vomiting, oliguria, hyperreflexia with clonus, this is something new, sudden severe rise in blood pressure, altered sensorium or loss of consciousness, seizures or convulsions. So overall these signs suggest that eclampsia is imminent. Coming to investigations, so urine analysis is number one, then comes blood investigations, then comes fetal assessment. So urine analysis greater than 0.3 grams per proteinuria of greater than 0.3 gram every 24 hours, or dipstick greater than or equal to 1 plus. Blood investigation on CBCVC, thrombocytopenia. This was one of the criteria. Elevated liver enzymes, AST, LT greater than 70, RFT, creatinine, increase in creatinine greater than 1.1 milligram per DL, urine serum uric acid elevated in severe cases, coagulation profile, PTA, PTT, fibrinogen levels for HELP syndrome. HELP meaning hemolysis and low platelets. Elevated liver enzymes too, and then fetal assessment, non-stress test to assess fetal well-being, and ultrasonography with Doppler evaluation of fetal growth restriction, oligohydramnios and uteroplacental insufficiency. Amniotic fluid index to rule out oligohydramnios. So these are the fetal assessment tests, NST, not NFT, ultrasound with Doppler and amniotic fluid index. Management of severe preeclampsia at 34 weeks of pregnancy. So first one, immediate hospitalization, next one antihypertensive therapy, next magnesium sulfate for seizure prophylaxis, corticosteroid therapy, delivery planning, and finally postpartum monitoring. So let's go look at each of them one by one. So admit to a facility with intensive maternal and neonatal care, continuous BP monitoring and fetal surveillance, strict fluid balance monitoring to prevent overload. So these are initial things that we need to do: admission to intensive care, continuous BP monitoring and surveillance, and fluid balance need to be maintained. Coming to, this is a hypertensive case. So what do we do? Antihypertensive therapy. So what are the drugs during pregnancy? One is labetalol or hydralazine, nifedipine. These are the three main drugs. So labetalol 100 to 200 milligrams orally BID, hydralazine 5 milligram IV every 30 minutes PRN. I know it, but I have forgotten what it is. As per requirement, as per requirement, nifedipine 10 to 20 milligrams orally BID if oral medication preferred. Target BP less than 160 over 110 but greater than 140 over 90 mmHg. So labetalol 100 to 200 oral BID, hydralazine 5 milligram IV every 30 minutes, nifedipine 10 to 20 milligram orally BID. Target BP less than 160 mmHg but greater than 140 over 90. Coming to magnesium sulfate for seizure prophylaxis, loading dose is 4 gram IV over 20 minutes. Maintenance dose 1 gram per hour infusion, IV infusion. So loading dose 4, maintenance 1 gram per hour IV. With this we also monitor deep tendon reflexes, urine output and respiratory rate. Watch out for magnesium sulfate toxicity. So what are the signs? Loss of reflexes, respiratory depression and cardiac arrest. So 4 gram IV over 20 minutes, 1 gram maintenance is 1 gram per hour IV infusion. Deep tendon reflexes should be monitored, urine output and respiratory rate should also be monitored. Watch out for magnesium sulfate toxicity. Coming to corticosteroid therapy, if less than 34 weeks, betamethasone 12 milligram IM, 2 doses 24 hours apart for fetal lung maturity, helps reduce the risk of neonatal respiratory distress syndrome. Then coming to delivery planning, immediate delivery if. So we have seen in case of premature, what do we do? Premature impending. So in case we have to deliver, in that particular case we do this particular thing, betamethasone for respiratory distress. Delivery planning, immediate delivery if uncontrolled BP or progressing organ dysfunction. and HELP syndrome or non-reassuring fetal status. So in this particular cases, uncontrollable BP, organ dysfunction, HELP syndrome or non-reassuring fetal status, we do immediate delivery. Induction of labor preferred if cervix is favorable, and then C-section indicated if severe preeclampsia persists despite treatment, fetal distress present, eclampsia or placental abruption occurs. So painful bleeding. Next, coming to postpartum monitoring. BP monitored 48 to 72 hours postpartum. Continue antihypertensive therapy as needed. Assess for postpartum hemorrhage due to uterine atony and neonatal monitoring for prematurity related complications, because we are delivering immediately after this particular point of time, when we realize that everything is haywire. So with this we are clear with preeclampsia, which is a very important topic which could come along with along with this as a 10 marker. So in case you like this particular video, you can like it. In case you would like to watch more of such videos, you can subscribe. Bye bye.